want to talk about a sore throat from manual professional edition. We will have differential diagnosis in this subject, and we will start with the differential diagnosis. Now, tonsillopharyngitis is maybe the most common cause of infectious cause of the pharynx or sore throat. Usually, more commonly, it's a viral infection. Can be adenovirus, rhinovirus, coronavirus, many viruses. It usually comes with rhinorrhea, cough, erythema, sometimes exudate on the tonsils, cervical lymphadenopathy can be, and no fever usually, or only mild. Now, strep throat can be a more overlap. It can really a lot overlap with viral tonsillopharyngitis, but usually it is more severe. There are the Centos scores that tries to differentiate between them, which says that usually strep comes without rhinorrhea, without cough, high fever, exudate on the tonsils, cervical lymphadenopathy, which is tender. This is more commonly with strep throat, and if we have this constellation of high fever, no rhinorrhea, no cough, cervical lymphadenopathy, and enlarge and exudate on the tonsils, it tells us that it more probably be a strep throat and not a viral tonsillopharyngitis. You can see here the characteristics that Meg tells, which is severe throat pain, fever, rarely rhinorrhea or cough, usually without, marked pharyngeal erythema and with exudates, and usually tender cervical lymphadenopathy. You can find all of this in the Centos Score, which tells that as you have higher score, more likely to be strep. And there are arguings in what score you can give antibiotics. Empirically, usually 4, some gives it with 3, when you should do throat culture or only rapid strep test. It depends on who you ask. So you can try to identify the strep using rabbit strep test and throat culture. Now, throat culture is more of the gold standard test for strep throat, but it's timely, it's sometimes hard to do. Rabbit strep test is usually more uh, common, usually more convenient to do and more rapid. And but the problem is that it has high sensitivity but low high specificity but low sensitivity. I mean, if the patient comes to be positive in the test, the patient is probably positive. But if the patient is negative in the test, there are about 20% that the patient is has strep and the test just missed it. The rapid strep test that missed it. So rapid strep test is okay. So because of this, some of the guidelines says that do a rapid strep test. If it's negative, do a culture. If it's positive, treat with antibiotics. Now, as you can understand, the treatment for strep is antibiotics. um, Penicillin. Strep didn't become resistant to penicillin even though it is treated with penicillin for many years. Usually penicillin like Penrafa, penicillin G, and everything like this can be enough. We are giving today for 10 days. There are some studies that say less, but okay, today we are giving for 10 days. Infectious mononucleosis that can be similar sometimes to strep can also cause high fever, fatigue, without usually upper respiratory tract infection symptoms, usually young adults and adolescents, pharyngeal tossing erythema and exudate, bilateral lymphadenopathy, sometimes posterior lymphadenopathy, cervical lymphadenopathy, sometimes splenomegaly, which can be hard to identify in physical examination. You can test for it, but it's sometimes hard to differentiate it from strep, and sometimes those patients get antibiotics. And one of the characteristics is that the patient with EBV or CMV, namely infectious mononucleosis, gets antibiotics, penicillin, and then develops a rash because it is more common to develop a rash in Epstein-Barr uh, while using antibiotics than something else. I mean, it's more common to develop a rash when using antibiotics in Epstein-Barr virus infectious mononucleosis. It can happen without, but it's more common with maculopapular rash usually. Okay, abscess parapharyngeal is usually a complication of strep throat. It's an abscess like paratonsillar abscess, a retrotonsillar abscess more in youngs, and it's characterized by hot potato voice. It sounds like the patient says hot potato in the mouth and they're having hard time to talk normally. The ovula in the physical examination is usually deviated to the opposite side of the abscess because the abscess just push the ovula to the contralateral side. The patient may have trismus, which is a difficulty in opening the mouth fully, and severe throat pain and high fever, odinophagia, and drooling may happen sometimes, and usually a paratonsillar abscess can be treated clinically with drainage sometimes when it's more complicated, so imaging is needed and everything. But needle aspiration and culture may be sometimes enough, of course, antibiotics and everything, for the underlying cause. Epiglottitis may be a very severe disease. It is less likely today because of the vaccination of children for Haemophilus influenza type B, which was the main cause of epiglottitis. Epiglottitis is, as the name suggests, inflammation of the epiglottis, which usually, again, was caused by Haemophilus influenza type B, and we are vaccinating against him. We are vaccinating against him. Children's in the vaccination series as a childhood, and because of this is less common. It's a very dangerous and severe disease. The patient can have stridor, difficulty breathing. The patient may sit lying forward, drooling, having hard time breathing. And the very characteristic thing and important thing to remember in this is this patient, if he has epiglottitis, if you check him, if you do physical exam, when you just putting the uh, tongue depressor, he can close his airways immediately. Therefore, if you suspect epiglottitis, it is better to do a physical examination in the operating room where you have immediate options for treating obstruction of the airways. So it's very important and very dangerous, the epiglottitis. Sometimes lateral X-ray can identify it, but it prone to false positive if it's not true lateral, if it was in exhalation, it is prone to false positive. Um, so sometimes what is used is flexible laryngoscopy, flexible fiber optic laryngoscopy, as you can see here, and again doing it in the operating room for the case the patient just closed his airways. Usually it is or was in children because of the vaccination, it's less common. Okay, so epiglottitis may be a very dangerous disease. This list is of infectious causes of a sore throat. Of course, if the patient has, I don't know, cancer of the oropharynx, he may have throat pain. So not just infectious disease can cause it. So now Merck starts to talk about it in etiology. The most common cause in tonsillopharyngitis. Most commonly, tonsillopharyngitis comes from viral infection, as you can see here, but sometimes from bacterial infection. And from bacterial infection, the most common is group A beta hemolytic strep, especially in children. You can see here that it is around 10 to 25% of all sore throat in adults, and slightly more in children is from group A beta hemolytic strep. Now you remember that we are treating it for some reason. One is to prevent the acute complications, as we talked about peritonsillar abscess. Maybe I can show the peritonsillar abscess here. you can see peritonsillar abscess. You can see the abscess here in the tonsil and around the tonsil, and you can see here the ovula, how it is deviated and pushed to the contralateral side. This is one of the signs that a peritonsillar abscess developed. Compare it to a very look severe but without peritonsillar abscess of a tonsil of a patient with strep pharyngitis. You can see here the exudates. You can see how swollen the uh, tonsil is, but you can see that the ovuli is in the midline, it's not deviated. The patient can open the mouth, he doesn't have a trismus. If I were to talk to this patient, I probably wouldn't hear a hot potato voice because the patient doesn't have peritonsillar abscess compared to this one, which probably when I will talk to him will have high fever, difficulty maybe opening the mouth, hot potato voice. This patient has peritonsillar abscess, maybe you need a drainage here. Okay, so abscess is what we showed, and epiglottitis can be from Haemophilus influenza type B. Thanks God we are vaccinated, so it can be from other bacteria, which is less common, so it is more common in adults or in children which were not vaccinated. Another name for epiglottitis is supraglottitis, just for you to know. Okay, so another peritonsillar abscess, you can see it here, driving the ovula for the other side. Now here it's quite difficult to see, but you can see the bulging, the big bulging here of the abscess. Okay, so of course you will look for the sign for what you look for. If you are looking for viral infection, look for rhinorrhea, look for cough, look for not very high fever, look for tonsils that look okay, look for something that looks viral. If you're looking for or differentiated from strep, look for no cough, no rhinorrhea, high fever, tonsillar exudate, which can also be in viral infection. Tonsillar exudate, okay. Look for lymphadenopathy, which can also be in viral infection, and try to differentiate. It's not very easy. I mean, you can't totally differentiate because there is overlap. So we use the rapid strep test or cultures, which is quite sometimes problem, and there are different I don't know to say guidelines arguing how to approach this idea, if to give empiric antibiotics or not, when to give, what Centos score, in what Centos score and to above of it to give antibiotics, when to do culture, when to do rapid strep test. It's not very clear cut, but okay, Harrison also talks about it. Red flags in pharyngitis is stridor, other side of respiratory distress. Maybe the patient has epiglottitis, maybe he has peritonsillar abscess which obstruct the airways. Drooling, which is one of the signs of epiglottitis. Muffled hot potato voice, which can tell us that maybe the patient has peritonsillar abscess. Visible bulge in the pharynx, again peritonsillar abscess suspicion. Okay, so here it tells us about other things that are more rare that can cause pharyngitis, tonsillopharyngitis. The first one is infectious mononucleosis, again, hepatosplenomegaly, general adenopathy, which can be also in the axilla and groin, and fatigue, malasia, above 1 week. Pharyngeal gonorrhea if there is recent oral genital contact, namely oral genital coitus, namely oral genital sex. A dirty gray thick tow membrane on the pharynx that bleed when peeled away. Diphtheria, which if the and try to understand if the patient was vaccinated in the with the Tdap vaccine in the childhood vaccinations, as we are vaccinating for Tdap, which is tetanus, diphtheria, and acellular pertussis. So the patient should be vaccinated, which reduces the likelihood of diphtheria. But if you see dirty gray thick membrane that bleeds when you peel it off, try to think of diphtheria. And if there are risk factors, for HIV, think about HIV, which can again cause lymphadenopathy, throat pain, and if it's very advanced, it can cause lymphopenias, CD4 destruction, and etc. etc. If there are risk factor tests for its HIV infection, we serology, and everything else. So, how we treat it? If we have strep, we can treat it with antibiotics. If we have severe symptoms, even the patient can be started on broad spectrum antibiotics like augmentin, amoxicillin, clavulanic acid. But remember that generally, strep should be susceptible to penicillin, so penicillin should work. But we have the other rare infections that can cause it, so maybe this is the reason. Merck tells us that if the symptoms are severe, you can start with broad spectrum antibiotics like amoxicillin clavulanic acid, which also called augmentin, usually 875 milligrams twice daily. And okay, symptomatic treatment can also be given in corticosteroid. It's not universally accepted, but corticosteroid can be given for tonsillopharyngitis that appears very, let's say, severe with pose risk of airway obstruction, for example, from mononucleosis or severe tonsillopharyngitis symptoms. We are trying to reduce the size of the tonsillopharyngitis. It's not, again, universal accepted and very hardly evidence-based, but okay. Okay, so this was general explanation about throat pain, differential diagnosis, and the common causes and how to approach it and to treat it. Don't forget the Centos Score. It's very important. The Centos Score, again, no cough, no rhinorrhea. This is 1 point if the patient doesn't have it. Lymphadenopathy, cervical lymphadenopathy, which is usually tender, another point. Exudates and swollen lymph nodes, swollen tonsils with exudate, another point. And fever, another point. So we have 4 points of the Centos Score. If we have 0 or 1, probably the patient has upper respiratory, which is viral. But if you have more than 2 or 2 and more, you need to think about taking a culture, taking rapid sweat test, consider treatment, empirical treatment with antibiotics, if the patient, especially if the patient has 4 criteria of the Centos Score. So the Centos Score is very important to evaluate the patient. Even though it's not gold standard for identifying TREP, it's very convenient. It's very easy to apply. Again, it's not 100%, even not close, but it gives you a direction. So don't forget to understand the Centos Score criteria. Maybe I will show you the Centos Score criteria. You can see it in MD Calc, and you can see here the Centos Score. It says it takes the age because younger patients around 3 to 14 are more likely to have strep. Now, under 3, the risk for strep is quite low. So there are those who don't even think about it under 3, but I will not talk about it. Because group A strep rare under age 3, this is the reason. So those are the 4 Centos Score criteria. If he has exudate, put 1, or swelling of the tonsils. Tender or swollen lateral lymph nodes, put 1. If he has fever, put 1. If he doesn't have cough, it will give you another point. Now, if you have 4 points, for example, you will see they will tell you to consider rapid sweat test or culture or empirical antibiotics. But if I have very low Centos Score, like 0, it will tell me that no further testing, no antibiotics needed. When I get to 2 points, it tells me to optional rapid swab test. If I am just 1 point, it tells me it's viral, no further testing, antibiotics. If I am on 3, it will tell me consider rapid testing and or culture. You can see that the consideration and the decision between rapid swab test and culture is not straightforward. Again, rapid swab test is less sensitive than the culture, so put it in mind. Some use rapid swab test. If it's positive, treat. If it's not, send to culture. And in the meantime, it does the culture. We are waiting for the results. Sometimes they even starts antibiotics. It depends on how bad the patient is. Okay, so this was about sore throat and differential diagnosis. Thank you very much. If there are any correction or mistakes, please tell me. Thanks for Merrick Manual Professional Edition. And that's it.